All right. So the chat is live basically, so we can comment and what's it called? Um, so we can comment and chat live basically. So the chat is on. So if you want to make a comment, you can comment live so I can see what's going on within the audience at the moment. Is that okay? Oh, fantastic. Okay, so we're having our people joining already. So welcome everybody to this presentation. My name is Dr. Moshapefolowa Odufayo, and it's a big, it's my joy. I'm delighted to be doing this, making this presentation to us um, this evening. I am really excited making this presentation this evening. It's my joy to do what I love to do and share knowledge with people who are what's it called, who are desirous of receiving such. And today I'm going to be what we're going to be doing with this webinar is to strengthen skills already present in healthcare providers, which is the ability to do some basic kind of scans. If you're here and you're listening to me right now, it's what's it called? It's most likely that you are a healthcare provider. You probably have some access to an ultrasound machine um, in your facility, and basically you have done one or two scans before. This particular lecture or this particular webinar is for you because one thing that is my goal is to make sure that standard skills are spread across board um, and across all areas or places of practice to make sure that the best outcomes are given to clients. The best outcomes are given to clients. It's very important. We've seen quite a lot of things in practice, especially in Nigerian practice, wrong diagnosis, wrong clinical judgments, wrong clinical impression, abortion of live babies, that or babies who of embryos that still had the potential to grow. Yeah, we've seen all of those kind of stuff happen. And so in trying to make sure that we can catch it, there are two ways. Either you really confront those kind of places or confront those kind of things, or you make sure that the knowledge available gets to everybody in current practice. Is that okay? And so we're here to strengthen the what's it called? The skills of many healthcare providers, especially at the point of care. And this is not just going to be the only webinar. It's not going to be the only one. There will be many more of its kind, specifically at the last week of every month. And many of them are going to be in continuum. For example, what I'm going to be talking about today, we're going to talk about it extensively today. And then we're going to also talk about a very important subset of it next month. So as many people as you know that will benefit from this, this is very important that you tell them to join. Ultrasound with Dr. Shokwe is trying to make sure that we are revolutionizing standard practice. We're revolutionizing practice and converting it into the best standards, especially at the point of care, basically. Such that many healthcare providers all around the country are doing the best that they can to make sure that the lives of every citizen is in safe hands. So let's begin. We're welcome. So first trimester point of care ultrasound, focused assessment of gestational age and early embryonic well-being. My name is Dr. Chopin. So today we'll be talking about the best assessment standards, the best assessment technique, the latest facts the most important guidelines that you need when you are holding a probe and you're presented with someone who has what's it called, who is currently suspected pregnant or has been confirmed pregnant with an ultrasound scan, but within the first trimester. Either the person is coming for the first time to your facility, or the person has gone somewhere before and needs a second opinion. So what to do? You're going to be equipped with that knowledge. In addition to that, I would also be laying the foundation of excellent what's it called, scanning techniques for you as well. So welcome on board to this. Under this particular presentation, I'll be speaking on the introduction, approach to first trimester obstetric cases. I'm going to recap the 3 trimesters for you. I'm going to recap some very updated term pregnancy definitions. I'm going to talk about the fetal heart, and then I'm going to be talking about first trimester anatomy, and I'm going to be talking about some parameters that are needed in the assessment of first trimester well-being in the of fetal well-being in the first trimester, and then we'll conclude on some few things. We'll do some quizzes, and then we'll conclude. By the end of this lecture, you will be able to properly handle a first trimester case when you see it, at least to be able to make a diagnosis of whether it is viable, whether it's non-viable, and then also too, you'll be able to make an assessment, or you'll also be able to make an informed decision of what your client is supposed to do next when you see such kind of cases. So, introduction. First trimester ultrasound scan is a vital diagnostic tool in prenatal care. So you're doing a very important job by doing this. It provides valuable insights into fetal development and maternal health during the critical initial 13 weeks of pregnancy. And so you get a lot of information from your first trimester scan. And it's very reliable, extremely reliable within 6 weeks and 13 weeks and 6 days. Now, from the presentations that we're going to be making, you will see that you can double down a little bit on that 6 weeks and say probably about 5 weeks, we can begin to do such kind of scans. And then up until the 13th week and 6 days, this particular knowledge will serve you in attending to clients. It plays a very crucial role in assessing fetal viability and growth. We can confirm gestational age and the due date of delivery with this scan. We can detect some potential fetal anomalies and abnormalities. We can evaluate multiple pregnancies through this particular kind of scan. We can identify ectopic pregnancies or miscarriage risks, and we can guide prenatal care and decision making. But in this particular lecture, we're going to be emphasizing on how to assess fetal viability and growth and confirm gestational age and due date. Okay, so there are 2 approaches when you see somebody come to your facility for a scan of their baby and you have an idea that this is going to be a first trimester pregnancy. There are 2 ways you can go about it. There's the transvaginal route. You can take a transvaginal probe, plug it into the woman, and then see what is going on there. And you can take the transabdominal route as well. Is that okay? But you also need to be able to make a good judgment on when to use what. Transvaginal ultrasound is very important, by the way, but we will rather now want to pay more attention to it if in the first trimester we are really dealing with a very early pregnancy, very, very early pregnancy. And also to mention, sometimes when the woman has the individual has a huge body habitus, and we have a very huge layer of fat in between the probe, the skin, and the uterus, such that if you put a abdominal probe or a curvilinear probe on the skin, because of the fat, there might be significant attenuation of the sound beams, such that when it's getting to the uterine cavity, it might not allow you see well. Then in such kind of cases, you can now use a transvaginal ultrasound probe, an endocavitary probe for transvaginal ultrasound. But like I said, as the embryo begins to grow, the transabdominal ultrasound plays a very vital role in the evaluation of the baby. And so let me now, I've been saying first trimester, second trimester, third trimester. Let's be objective about the trimesters. When we're talking first trimester, we're talking the first day, of conception, which will be calculated, we would calculate from the first day of the last menstrual period up until the 13th weeks, up until 13 weeks plus 6 days. First trimester, that's it. When we clock the 14th week, we started second trimester. And second trimester will end 27 weeks and 6 days. Once we move from 27 weeks and 6 days and we enter 28 weeks, and then we go from 28 weeks till delivery, that is third trimester. So objectively, when we have 13 weeks and 3 days, that's still first trimester. 13 weeks, 4 days, that's still first trimester. 13 weeks and 5 days, that's still first trimester. 13 weeks, 6 days, that's still first trimester. And this criteria is by the American College of Obstetrics and Gynecology. And so take note of that. When you're making, it's very important when you're making your assessment on your report. Now, also too, let me just clarify this. Although we're talking about first trimester, I just felt to also make you understand some things about term gestation, basically, because I've seen reports where the pregnancy is 36 weeks, and I'm seeing term gestations in the report. So in order to make sure that we understand what term gestation is, I've put this here. Recently in 2012, the American College of Obstetrics and Gynecology also helped to iron out the discrepancies in the terms people use in addressing term gestation. So we've now arrived at anything from 37 weeks to 38 weeks and 6 days is the early term. Anything from 39 weeks to 40 weeks and 6 days is full term gestation. And then we have late term being from 41 weeks to 41 weeks and 6 days. And then it becomes post term, 42 weeks and beyond. So it becomes post term when 42 weeks and beyond. And so that's according to the 2012 criteria. So we've understood some of these things now, yes. We've understood some of the terms. Now, let's now begin talking about first trimester ultrasound scan and the fetal heart. First trimester ultrasound scan and the fetal heart. This is very important. The fetal heart is the dividing line between when you call a pregnancy viable and when you say it is not. Let's go further and talk about it. A viable fetus or embryo, is one with cardiac activity. There should be no mention of a viable gestation if you have not seen the cardiac activity. There should be no mention of viability, like this fetus is viable. There should be no making a judgment of viability if you have not seen the cardiac activity. It's very important. So it's the fetal heart rate that tells us whether this baby is officially alive or officially not alive. Is that okay? And in places where we cannot see the heart rate, then viability is queried. And then that combined with some other factors that we would eventually learn later, we can now then determine whether we might just need to give some time before we see the heartbeat, or at this current moment, that baby is not alive anymore. So what's the normal heart rate? Now, take note, look at these two values I've given. In early first trimester, up to about 12 weeks, we can allow for a wider range of heart rates. Is that okay? Between the ranges of 80 and 180, it's okay. But from late first trimester onwards, 110 to 160 applies. Let's break it down. Why do we allow for such a huge rate at the earlier times? It's because a heart rate of about 80 beats per minute will only be very normal at the very first stage, specifically around that 5 to less than 6 weeks, when you can see it with a transvaginal probe. Remember, we said early is TVS. And the rate would increase till about, can increase till about, and pick up until about 180 beats per minute, up until about 9 to 10 weeks, and up to 11 weeks. And why? This is because of the developmental fluctuations of the sympathetic and the parasympathetic nervous system. Yeah. So, one develops before the other, basically. So, it's said that around the early periods of gestation, the parasympathetic takes its own effect first. And so, therefore, that brings the heart rate to a point of being very slow. Then when then later on, the sympathetic comes in, sometimes takes it to overdrive, basically, and brings it up. So there is quite a lot of irregularities when it comes to the heart rate as a result of fluctuations in a sympathetic and parasympathetic nervous system that is just trying to get itself, because neurons are beginning to form. However, as it begins to, as more development takes place, stabilization occurs, and then we now arrive at the regular rate we know. So when we see a rate under 100 beats per minute, usually after about 6 weeks and 4 days, or over 180, after that 9-week, 10-week, 11 weeks, sometimes up to 12 weeks window, what we do is to just consider this situation as, take note of my words, concerning. I didn't say pathological, concerning, and it will require medical follow-up. So, because why I said concerning is, it could just still be that overdrive or fluctuations that we're talking about, or it could be something else in the background. And so for us to be able to determine which is which, what we then have to do is to just tell the client, hello, okay, we just picked some few things in the heart rate. Okay, we just want to just follow up on that. So you can come back for a scan in about maybe 1 to 2 weeks if you'd like to, or you can just hold on a little bit and then we can just check the heart rate again before you go. Is that okay? So, but just take note, usually first trimester up to 12 weeks, 80 to 180 is allowed, basically. But then if we are now beginning to raise to that 180, maybe around the 10th week, let it just raise a concern to you and then just allow for a follow-up. Is that okay? Good. So now let's now talk on first trimester sonographic anatomy. Let's talk on it. So in talking about first trimester sonographic anatomy, I want us to understand some things concerning conception, and then we'll now relate it to when we begin to see these things on the scan. So to understand that, we're going to be using a very fantastic example here. This is a very beautiful lady, as you can see. Her name is, I call her Lady Buddy. And then her last menstrual period was the 1st of February 2026. So just take note of these dates I'm giving you. Let's see her profile. A cycle length is 28 days. A flow length is about 4 to 5 days. And we should be expecting to see our next, flow in March, or our next cycle should begin in 1st of March. So this is just a very ideal example that I'm trying to give us so that we can understand the relationship between the weeks pregnancy form and the weeks we begin to see them. And so Lady Buddy, 1st of February was when she saw her period. She was excited when she saw her period. Then normally a period will last for 28 days, and that's how it has always been. and then she'll flow for the first 5 days. And so right now that she had seen her period on the 1st of February, she's like, okay, oh, 1st of March, I'm going to see my period. But her name is Lady Buddy for a reason. She likes hanging around a lot. And so before she does some of her hanging around, she decides to do a brief pelvic scan, and she did it around the 7th of February after she had finished. Oh, okay. After she had finished the last period. Okay, let's see if we can zoom in it a little bit, because I can see that some people want us to zoom in. Okay. Oh, sorry about that. Okay, don't worry, it's going to get bigger. I'll try to, what's it called, make sure, I'm trying to make it a little bit bigger, but I didn't factor that in. So I'll try to read through everything and work on the zooms. So like I was saying, she did a scan on the, what's it called, on the 7th of February. So this is like technically 6 days after her last menstrual period. And everything looks fine. So this is how a classic pelvic scan looks. Here we have the uterus. And then we can see this white line in the middle, and that's the endometrium. Yeah. And that's the endometrium. And then so this here is the endometrium. So that white line, then we have the uterus here, and then right in front of it we see this black hole, and that's the bladder. So that's the way it looks, just like this many times. Yeah. So this is a perfect non-pregnant uterus, and this is the way it ought to be for her every single time. But so she's excited because nothing is wrong with her. And so out of the excitement, she goes around, and then she meets this fantastic guy. His name is Mr. Pablo. And then now take note, if her last menstrual period is about the 1st of February, then most likely she's going to be peri-ovulatory and ovulatory, maybe somewhere between the 10th of February and 14th of February. Yeah. So she meets Mr. Pablo, yeah, on the 14th. So it's most likely she had released an egg at that moment in time, but she was pretty much careless. So she didn't see that coming. So, and now after meeting Mr. Pablo, what happens? They have a fantastic time, and then they drive home, and then they meet on that 14th day. On that 14th day, they meet on that 14th day when the egg is already present. Whether it was released that day, we don't know. Whether it was released 48 hours before that day, but they have met, and then something happens. Say something happens. Something happens. And so let's follow it up. On this 14th day of February, Pablo's sperm goes through the uterine canal, through the fallopian tube, and meets with the ready egg, which is over here. Is that okay? And then when the sperm fertilizes the egg, conception takes place on the 14th of February. So I want you to start counting. This is 2 weeks after the last menstrual period. 2 weeks after the last menstrual period, conception takes place. Yeah. And then within 24 hours, a zygote has formed. So that's like, maybe let's say like 2 weeks and 1 day. And then within another 24 hours, we have it dividing and dividing again. And then this is day 4. We are already in that 16-cell stage, which is the morula. This is just embryology that I'm talking about. Then the very important thing is that after the morula happens, we begin to have what we call the blastocyst, which is that all these multiple cell clumps that have arisen as a result of cell division, they just make space within its center, and then we now have a fluid collection there. And then that huge cell clump of cell moves, that huge cell mass moves to one end of your, what's it called, of the developing embryo, yeah, but at this stage we know it as the blastocyst. So you have fluid over here, and then you have all those cell masses, and then you have this one surrounding it. And then around 6 to 7 days after conception, which is 2 weeks after the last menstrual period, yeah, this particular thing that will have been around the egg, called the zona pellucida, starts dissolving properly. And then around the what's it called, the 8th day, day 8, day 9, something happens. That our blastocyst, that our nice guy called the blastocyst, begins to implant into the womb. It begins to plant itself, so it digs into the womb. But this 6th, 7th, 8th, and 9th day, yeah, this period coincides with a period where this blastocyst specifically, a part of it, especially that part that is trying to burrow into the womb, begins to, what's it called? Begins to secrete what we call the beta HCG. So that takes place about 1 week post-conception, yeah? And 3 weeks after the last menstrual period. This beta HCG is what we see is produced by the syncytiotrophoblasts. And remember, it's produced around the 6th to 9th day. Around this period, it begins to sweat it out. Is that okay? This beta HCG is what we now use to detect via the blood or via the urine whether a person is pregnant. Is that okay? So it's very rational to say that the earliest time you can therefore detect your beta HCG will be around maybe 3 weeks 3 weeks from your last menstrual period, or about 1 to 2 weeks post-conception, because production will begin around the 6th day post-conception, around the period where the blastocyst forms and it begins to release it. Some studies have shown that it can be even released as early as the 8th cell stage, but we don't really, what's it called? We might not read, that might be too early in certain instances. So what I want you to always have in mind is that 6 to 12 days post-conception, that's about 1 week post-conception, 1 week and some days post-conception. Conception is when the sperm met the egg, and that will be like 2 weeks after the last menstrual period. Beta HCG is positive. And so beta HCG, which will be well detected first in the blood and then in the urine, can be used for early pregnancy tests around this period. Around this period, we might not even see the baby yet on the ultrasound scan. But let's move forward. And so serum beta HCG will therefore be detected around 3 weeks after. If we say we're going to start counting using that 6 to 12 days, it will be like around the 23rd to 24th of February. Yeah, basically. And so, but you know, at this period, she's not even expecting to see her period yet, because I said she's on a 28-day cycle. She's not expecting. So it's possible for you not to have even seen the period, basically, but we can already detect in the earliest form, beta HCG, in its highest form, to confirm that you may be pregnant. And so that's the, what's it called, the implanting blastocyst there. And so what now happens is 1st of March came, she didn't see it. 2nd of March came, she didn't see it. 3rd of March came, as you can see, she's pretty frantic. And this 3rd of March is already about 1 month and 3 days, or about 31 days from her last menstrual period. Now she's seeing that something has already happened. She's already seeing that something has happened already. So, and okay, I'll come back to this slide. So, and then she's frantic. And so on that 3rd of March, she drives to the hospital and she goes for a scan. She goes for what? She goes for a scan. So what then are we supposed to see on the scan from this period onwards? Before I talk about this, let me bring you back to this table here. This is just a table that, what's it called? shows us the beta HCG levels. Yeah. So we are seeing the beta HCG levels here. Yeah. Okay. So we're seeing the beta HCG levels at this moment. Look at it, 3 weeks, 4 weeks. I'll answer all the questions towards the end of the meeting. Is that okay? So we can put the questions on the tab box, if on the comment section if we have them. So we can see that 3 weeks post-conception, which is around that period when the blastocyst implants, it's about 5 to 50. 4 weeks it increases, 5 weeks it increases. Now, key points, I don't need you to cram these values. It's not necessary to cram them. The only thing I want you to see is to observe the trend, because for someone who is having a developing baby, there are dramatic geometrical increase in beta HCG levels with time. Is that okay? Then it peaks around the 8th week, basically. So 8th, 9th week. So dramatic increase in beta HCG up until the 8th week is a very, very, what's it called? Fantastic sign of pregnancy. So if we decide to plot a graph and we decide to take it, we'll see that it will keep increasing up until the 8th week. It's this pattern that matters to us, not necessarily the values, because the values can change for different people. The values can change for different people. And so therefore, know this for sure, such that if you want to then monitor pregnancy progression, when you cannot have conclusive findings from the ultrasound, collecting your beta HCG serially will help you in determining whether there is a progressing pregnancy or there is a pregnancy that might not be progressing, or there is no pregnancy at all. So that's one thing you need to know. The reason why the values are not important is because even in some certain non-pregnant states, yeah, you could still have beta HCG levels around this value, 55 to 200 nanograms per mil. However, take it the next day, it's still going to be 55. Take it the next day after, it's still going to be 55. It will keep being 55 for as long as possible when she's seeing her period. And then you can see there that beta HCG might be present, but if the pattern is not there of increased peak till 8th, 9th week, then we might not be thinking of a pregnancy. Okay, I trust that's clear. So she has gone to the facility at 31 days, 4 weeks, 3 days. And then what are we going to be seeing on the scan? Let's remember our scan on the 11th of February. Let's remember a scan on the 11th of February. So let's assume she did a pelvic scan. You can see it clear. She did a TVS, very, very clear. So now she insists on doing a TVS this time around, again, on the 3rd of March. And what can we see? On the 3rd of March, we can see that there is something that appears, a black hole around a thickened hyperechoic endometrium. A black hole around a hyperechoic endometrium on the 3rd of March. Is that okay? And this is what we call an intradecidual sac sign. Small hole, black hole. First sign of first trimester ongoing gestation. Sorry, not first trimester ongoing gestation. First sign of a first trimester pregnancy, intradecidual sac sign. This is the earliest thing you would ever pick if this woman is just some few days after our last miss, after some few days away from, some few days after an expected period. This is what you're going to pick. So this is what we're going to see on the 3rd of March. Will we be able to pick it that early, Dr. Shokpa, you might ask? Can you pick intradecidual sac sign at just 4 weeks and 3 days? Well, this is the answer to that question. I hope we've been able to take note of that. The thing is this, there's something called a threshold level, and there is also something called a discriminatory level. A threshold level is the earliest time you can ever see a particular sign. And this is that we have conducted multiple studies. We have plotted a Gaussian curve. Yeah, I hope you know what a Gaussian curve is. We've plotted a Gaussian curve, and we have looked at the standard deviation. And then we've seen the earliest days we can ever see a, what's it called? An intradecidual sac sign. And we have seen that even though it's not for all people, at least some people, we know that on the 24th day after their last menstrual period, we can find an intradecidual sac sign already present. So even on the 24th day. Now, this is body's 31st day. So we can, so therefore, the fact that we saw an intradecidual sac sign in our case, hypothetically, is true. Is that okay? So the earliest time to see a, what's it called? The intradecidual sac sign, which is just that simple black hole, as you can see again, within the endometrium, can be 21 days. And then the discriminatory level is if you are trying to see whether someone is pregnant. For example, maybe another lady comes. Is that okay? Maybe another lady comes and then she's saying, I think I'm pregnant, doctor. I think I'm pregnant. My last menstrual period was 1st of February. I've not seen it 1st of March. Okay, let's check it. You didn't see anything. This is 31st day. Then she comes back again on the 40th day. You check it. You didn't see anything. Then she comes back again on the 47th day post LMP, yet you still don't see an IDSS. Then it is most likely, you can conclusively say that this person is not pregnant. If you don't see the earliest sign of gestation up to 47 days after the last menstrual period, then it is most likely this person is not pregnant. So intradecidual sac sign is the earliest direct sonographic sign of sciasis and can be seen as early as 4 weeks and 3 days or 4 days, especially in this kind of clients. And remember, the threshold level is about 24 days. Now, not in everybody, you might not see it in everybody at their 24th day. In fact, you might not. It's rare, but it's part of the curve. It's part of the series of studies that have been done, and some people it's already present on the 24th day. Is that okay? But as early as 4 weeks and 3 days, or 4 weeks and 4 days, we can see it. And so that's it again. Small, tiny black hole within an endometrial echo, whether thickened or not thickened, you're going to see it there. Then as the sac begins to grow, we begin to appreciate another kind of sign, which is what we call the double decidual sac sign. Now, it's a useful feature in early pregnancy to confirm an early intrauterine pregnancy, even when the yolk sac or embryo is not visualized. So let me give you a trick. The first thing that we use to confirm, that we use to detect the direct sign of a pregnancy, is about the sac. The second thing we need to determine pregnancy is about what is surrounding the sac. Then the third thing we will now use to determine the pregnancy is about what is inside the sac. That's one thing you should note. So what's the double decidual sac sign? It's very simple. So if you look at this image at the bottom, remember just try to use your imagination. Remember that picture I showed you. When the blastocyst wants to implant, it will bury itself in the lining of the endometrium. It's not that it's going to stay inside the cavity. So here you can appreciate in this diagram below where I'm outlining green, you can appreciate the cavity. So the cavity is present. The baby doesn't just say, the embryo doesn't just stay suspended in the cavity. What happens is it digs a hole in the endometrium. Then when it digs a hole in the endometrium, it now uses, so imagine if you are digging a hole in a sand, you put your egg inside, then you now use sand to cover the egg. That's exactly what we're doing here. So it digs a hole in the endometrium, burrows into the endometrium, and then allows the endometrium cover it. So the endometrium that it burrows into, that it's lying on, is what we call the decidual basalis. That's the base, that's the endometrium, the floor it's resting on. Then the endometrium that covers it is called the capsule, obviously, because it's covering it. And then the endometrium that is at the other side, that was not involved in the implantation process, is the parietalis. And between the parietalis and the capsularis, yeah, we have the cavity. Is that okay? And so that's what we can see here. We see the double decidual sac sign. So the double decidual sac sign. So that's it. You have the what's it called? The basalis. What's it called? The endometrial cavity. So it's like 1, 2, then what's it called? Then 3 again, basically. So it's like the decidual sac is doubled. Is that okay? Basalis, basalis. Then you have the capsularis, and then you have the parietalis. So just take note of that. You might appreciate that more in a transvaginal ultrasound scan, because that one will outline the endometrium presently perfectly for you. Is that okay? Then after that, remember I told you around the sac, around the sac, now inside the sac. First of all, the double decidual sac sign will be visible usually around the 5th week. The intradecidual sac sign will be present 4 weeks, 3 days, 4 weeks, 4 days. Double decidual sac around 5 weeks. So this is what you should be looking for if a woman tells you her last menstrual period. A woman tells you her last menstrual period was 1st of February, yeah? And then she comes for a scan. She comes for a scan, and then this is probably 3rd of March, yeah? That's just about 4 weeks, 3 days. First of all, I don't see why you should be trying, first of all, to be doing an abdominal scan. First of all, I think you should suggest a TVS, because from the last menstrual period, she should still be around the age when she will be doing, what was it called? Except probably you just want to, you don't want to inconvenience yourself by doing a TVS. But ideally, around that 4 weeks and 3 days, just some few days, 1 to 2 to 3 days or 4 days after the last menstrual period, at that period, what you are thinking you need to find is the intradecidual sac sign. And you know that that's pretty small. So it's either you have a very, very good transabdominal ultrasound curvilinear probe that can see the intradecidual sac sign, or you just get down straight to a TVS to look out for the intradecidual sac sign properly. Or you tell the person to come back maybe when they are about 5th week to see the double decidual sac sign, which is a little bit more prominent on transabdominal in the, what's it called, as one goes. So the next sign, without wasting time, is the yolk sac, yeah? That one is like a ring that appears within the sac. So remember I told you the sac first is what happens, then next thing is what's happening around the sac, then the next thing is what's happening inside the sac. So the first thing that happens inside the sac is the visualization of the yolk sac. So what you have is a ring-like structure within that our gestational sac, yeah? Is that okay? And this one can first of all appear around 5 weeks and 3 days. And usually it will disappear around the 10th week. Take note, any yolk sac that you see that is more than 6 mm in diameter, suspect an abnormality. Usually it's never more than 6 millimeters in diameter. Is that okay? Good. So the yolk sac, when we want to measure it, we measure it from inner to inner. So we measure it like this. We don't come from outer to outer. That might just be very wrong. Is that okay? So we measure from inner to inner. Good. So, and we know its function is to provide nutrition. And then also to one thing you can use to note if there are early multiple gestations is the presence of more than one yolk sac. Is that okay? It's the earliest sign of a polyamniotic pregnancy or twin or triplets or whatever. Now, again, what's the next thing you are going to see? So we've seen the intradecidual sac sign, 4 weeks, 3 days, 4 weeks, 4 days. We enter into the double decidual sac sign, 5 weeks. Yolk sac begins to appear, 5 weeks, 3 days, 4 days. Then the next thing that happens is on that yolk sac, we now begin to have a particular area that is just non-uniform, a particular non-uniform thickening on the yolk sac. That is the beginning of every single individual that is watching me in this particular webinar today. You started as this. And if you see it, you can observe that it looks like that ring that you will use to propose to your wives. Is that okay? And that's why we call it the diamond ring sign. The diamond on the ring is the embryo, and the ring itself is the yolk sac. So every single individual watching me right now started as that diamond on the ring. Is that okay? And so this will be seen at the 6th week. Sometimes if you look very closely, zoom in, do all the focus you can use the transabdominal probe to see this, and sometimes even detect the heart rate on it. But that must be that you have a pretty good machine. Is that okay? So it can be seen as early as 6 weeks or 6 weeks and 4 days. From experience, I've seen it at 5 weeks and 5 days before, or about 5 weeks and 6 days. But you can see it's almost approximating 6 weeks. Is that okay? Yeah. So that's the diamond ring sign. And so then what now begins to happen to the diamond in the ring? As you can see, first of all, the diamond has gotten a little bit bigger. It gets bigger than the ring. So that's the embryo beginning to develop. Is that okay? And then it becomes a lot bigger. Is that okay? As you can see here, and the yolk sac is still over here. Then it gets to a point, it becomes way bigger. It's now pretty separate from the yolk sac. It's pretty separate from the yolk sac. Then thereafter, completely separate, surrounded by the amnion. Is that okay? So at this point, the baby is already developing. And, we're making good progress. Is that okay? So now, this is what we will see. This is how it will look sonoanatomically through the development. Now, in all of this, there are things we can measure to give objectivity to how old, how well the baby is doing. Obviously, the first thing we're going to want to check if all of this is even going to lead to a real life baby is the fetal heart. I had already mentioned that you would also have to see, sometimes you can also measure the size of the yolk sac, inner to inner diameter. That's like the earliest pointer to the presence of an abnormality. Is that okay? Yeah. And then let's now talk on the parameters proper that we'll use to assess throughout this developing anatomy, the embryo and the sac that surrounds it. We have 2 parameters we use, yeah? The first of the parameters, if you're enjoying this lecture, is that okay? You can share with your people so they can also, join in also as well. Yeah, there are 2 parameters that we use apart from the heart rate. Well, the heart rate just helps you check whether it's alive or not alive. Is that okay? But when we are talking about measuring and assessing age, well-being, and all of that, we're talking about the mean sac diameter and the crown rump length. Just those 2. One thing you need to know about these 2 is, as much as they can tell you a lot of details about the age of the baby, you can't use them to get the weight of the baby. Is that okay? As a matter of fact, what will you be using the weight for at that period? Is that okay? Serial measurements of these 2 parameters are accurate predictors of the fetal growth. Is that okay? And one thing you need to know about the crown rump length is, if you're going to get the best dating predictor, how really old this baby is, that is by the crown rump length. And that is usually done when the fetus is about 7 to 10 weeks. So what if you get something within 7 to 10 weeks, if you get a CRL that tells you this baby is about 7 to 10 weeks, that's most likely the accurate age of the baby. Is that okay? That's most likely the accurate age of the baby. And most likely the expected date of delivery that you will get from that will be the actual 40th week. Is that okay? Good. So that's very important that you should know. So let's move on to the next one. So let's talk about, first of all, the yolk sac diameter. Now, so the yolk sac diameter, like I mentioned, can be a predictor of fetal abnormalities. If you got a yolk sac diameter greater than 6 millimeters, it is abnormal. Inner to inner diameter of the yolk sac should not be more than 6 millimeters. It should be less than that. Head circumference can be included in the first trimester. I will tell you why. Why do we include head circumference in the first trimester? On some certain instances, yeah, the crown rump length may not be enough to, what's it called, adequately estimate the age of a baby, especially in the latter part of the first trimester, because you need a particular attitude the fetus must have for you to be able to measure what's it called, accurately the crown rump length. Sometimes the baby's attitude, and when I mean attitude, I mean the position. I mean like the flexion, extension, and all of that. Sometimes some attitudes may not favor, might not favor the best, what's it called, the best what's it called, the best measurements of the CRL. So you have to add things like the head circumference to it. Sometimes you need to add the BPD. So for a GA less than 13 weeks to 6 days with a visible embryo, the CRL is the best for assessing gestational age. If it's less than 13 weeks and 6 days, less than 13 weeks, the CRL is the best. However, take note of that period when I said you can begin to add the head circumference, because at a point it gets a little bit, what's it called? If the baby is not properly positioned, it might be very difficult to measure at that period in time. But nevertheless, between 13 weeks and 6 days and less, still is the best. Fetal head measurements may be included in the late first trimester to consolidate CRL measurements. Yeah, if the fetal neck and body flexion makes the CRL false. Like I told you before, sometimes if the baby flexes their neck too much like this, the CRL might not give you the best measurement. So let's now talk on the CRL so you can know exactly what it is. It is the shortest distance, a straight line distance between the top of the fetal head. So you're taking it from the top to the bottom of the torso. You're not taking it to the leg. You are not taking it to the umbilical cord. You are not taking it to the yolk sac. You are taking it from the top of the head and you are measuring it down to the bottom of the torso. That's the bum area. Is that okay? And then look at this. We can see the baby's head and we can see the, what's it called? The bottom of the torso. We have good cephalocaudal orientation because of differentiation. But in certain parts of the times of the pregnancy, for example, around the 7th week, 8th week, or in fact, even 6 weeks and some days, you can't say where the head is, you can't say where the, what's it called? Where the bum is. So, but you still got to take a CRL. That's why the next definition of a CRL tells us that when the fetal pole is poorly differentiated, it is a measure of the longest embryonic axis. So you rock your probe up until you get the longest axis. And then whatever you get as the longest axis at that moment is the CRL. It's the most accurate estimation of gestational age, and it's otherwise known as the fetal pole length. Let's move. So now this is an example of that wrong flexion I was talking about. See, the baby has flexed their neck here. We can't see it, so it makes this CRL a little bit short. Is that okay? And so this CRL is not good, this one here, while this one on this other end here is fantastic. Is that okay? Good. So now look at this one. Here we can see the head. We can tell that the head is around here. And then here we can tell the bum is here. So we can take the well-differentiated cephalocaudal regions. But contrast it with this one. I don't know where the head is. I don't know where the bum is. So, but what I do is I rock my probe until I get the longest axis. And there we have it, the CRL. Is that okay? Good. Then that's it again. This is another CRL. We can't really tell where the head is. We can't tell where the bum is. Take the longest axis. That's what's going to give you the CRL. in these two places. We can see that. So we can use it between the 6th and 13 weeks and 6 days. Accurately, it dates it by up till plus or minus 3 to 5 days. That is, you most likely will not be in what's it called? You will be very accurate when you get it. It's very accurate. Is that okay? And one thing you need to know about the CRL, which is just some theory you can have in your pocket, is it can increase by about 1 millimeter per day from 7 weeks till about 9.5 weeks. Just take note of that. Is that okay? Now, very important, these are the things that I have been trying to get us at. If your CRL is greater than or equal to 7 millimeters, you should find a cardiac activity. You should find the heartbeat. You should find the heartbeat. On the transvaginal ultrasound, if you see that this particular embryo with a CRL of greater than 7 mm, yeah, is without a cardiac activity, that baby is gone. That baby is gone. You can conclusively say it's gone. You don't find one greater than 7 mm without a heartbeat and still, well, you can still have hope, maybe for a miracle, but it will not be usually once it's greater than 7 mm CRL. For example, I measure this CRL right now, and maybe this CRL gives me 8 mm, and I don't find a heartbeat. That's gone. And what we call that is a missed miscarriage. Is that okay? Because in this kind of situation, probably the woman does not even know, and then she just came in for a scan. Is that okay? Yeah, so that's it. So now one thing we need to know is when we are comparing the CRL and the gestational sac diameter values, just take note of this. I think I'll still mention gestational sac in front. The difference between the CRL and the gestational sac diameter should be greater than 5 millimeters. For example, if the CRL you got was 14 millimeters, the what's it called? The gestational sac diameter should be at least 5 millimeters greater than that 14. So 19 and above. If it is less than 19, assuming the CRL was 14, it confers a poor prognostic index on fetal outcome, meaning that if you do a scan the next time, such kind of pregnancy might most likely not be alive the next time you do it, even if you saw a good heartbeat in the first instance. So a difference of less than 5 millimeters, what's it called, in MSD, between MSD and CRL, confers a poor prognostic outcome. When we see it, we see that, oh boy, I don't think this pregnancy is going to be fine. But we saw a heartbeat, trust me. If we come back next time, it's only by a miracle, it might not be fine. And this I have seen many times before. So for crown rump length, chromosomal abnormalities like trisomy 18 are markedly associated with growth restriction. So if somebody is having a what's it called, a crown rump length of less than the expected for age according to LMP, one of the things that might be wrong will be that there is actually an intrinsic abnormality, especially associated with the baby's chromosomes. Is that okay? So and then according to the American Society of Gynecology and AIUM, CRL less than the 5th percentile, consider growth restriction, then keep monitoring. Less than the 3rd percentile, evaluate for fetal abnormalities. But just know that if it's less than expected for gestational age, think about other things. So the next kind of scan you should be doing for this person who would probably have a what's it called, a short fetal short CRL, will be a knockout translucency scan between the 11th and 13th week. Other causes of of the crown rump length are growth restriction, chromosomal abnormal. You can see fetal factors, maternal factors, geriatric factors, and miscellaneous factors. Many of them. Is that okay? You can just briefly look at the table so you can see there are fetal factors, maternal factors, and all of this. Blah blah blah. All of these are causes of reduced crown rump length. Now let's talk lastly on mean sac diameter. Mean sac diameter. Mean sac diameter is what's it called? Is an average sonographic measurement of the gestational sac. Note this, an average sonographic measurement of the gestational sac. Usually it measures about 2 to 3 millimeters when first seen, maybe around 5 weeks after the LMP, around that period when you're probably seeing the IDSS, intradecidual sac sign. Is that okay? Yeah. And so the best way to take your mid-sac diameter is by taking the length, longitudinal section, transverse section, and anterior posterior section, taking the total, then finding the average. That gives you your mid-sac diameter. Take note of what I just said. I'm going to talk about it later when it comes to how we approach what's it called, early pregnancy assessment. You know, and normal mid-sac diameter, if you add 30 days to it, it can give the approximate date of pregnancy, but this is not so accurate as the CRL will give. It's also measured by taking the inner to inner diameter. Is that okay? And so again, to obtain the mid-sac diameter, look at the way the probe is handled here. We first of all take a longitudinal section by directing our probe longitudinally. Is that okay? And that gives us a longitudinal section. Then we take the longitudinal diameter or section. Then also too here, we can also take the anterior posterior. Is that okay? And then we now turn our probe transversely perpendicular to the longitudinal section. And then we take the widest transverse diameter. It is this average that gives us the, what's it called? The actual mean sac diameter. Now, some people do it quite differently. You know, there's something they do, which is what we call a single diameter practice. You'll see some people, they'll just look at the sac and just take one diameter straight up. Well, it is okay to do this if you are just trying to do a very quick assessment, especially even if the sac is early. You can't find the fetus inside and it still looks spherical, then it's most likely that whatever you get in all dimensions will be roughly the same. Or probably if you are in a very busy setting where you are seeing 60 to 70 clients per day, trust me, there are places like that, or even up to 100, and then you cannot afford to take all of the mean sacs. Is that okay? And you can't afford to take all of the dimensions. Is that okay? Then you will now be taking one diameter, but there is a limitation to it. There's a limitation to it. You can overestimate or underestimate the gestational sac size, especially if you have irregular or elongated sacs. For example, if you take a look at this particular sac, it's longer in longitudinal, it's longer here than it is here. If you just measured a single one at this point, it will be long. It will give you a advanced gestational age. In fact, it might even give you an advanced gestational age that you should be expecting to already see a yolk sac in. Then if you now measure it here, it's shorter. So that's why evidence-based practice tells us that orthogonal measurements, taking all three measurements and taking the average is the best. Is that okay? So now, the same way we said, if you have a CRL greater than 7 and you don't see a fetal heart rate, that baby is gone. It's a miscarriage. If you have a mean sac diameter greater than 25 millimeters and you don't see a fetal pole, that is not a viable gestation. That's most likely what we call a blighted ovum. Or in some cases, a miscarriage where there has been complete fetal resorption, which is that the baby has eaten up itself. It appears so hypoechoic, you might not be able to see it. For many cases, blighted ovum. Is that okay? So, greater than 25, blighted ovum. If the mean sac diameter, write this down, if the mean sac diameter is between 16 and 24, with no visible fetal pole, even on transvaginal ultrasound scan, you can suspect it is suspicious. I didn't say it is definitive. It's suspicious of pregnancy failure. And there is a diagnosis, we will call it. I'll talk about that in the, what's it called? In the in the next lecture. Is that okay? Okay, I can see some people are having some network issues. If the network issue is rampant, you can just tell me there is network issues. Is that okay? So I can what's it called? Know that. If it's not, you can just let me know. So there's an assessment, we'll call it. On transvaginal ultrasound scan, if the mean sac diameter is about 8 millimeters, you should be able to see the yolk sac at that period on TVS, on TVS, on TVS. Yeah. Nevertheless, if you don't see it, it's not a problem. The same applies for transabdominal ultrasound, but the measurement changes. Is that you should be able to see a yolk sac if the mean sac diameter is about 20 millimeters, mean sac diameter. Is that okay? Lack of it does not show early pregnancy failure. We don't use the yolk sac, presence or absence of yolk sac, to get early pregnancy failure, except if the diameter is greater than 6 millimeters. Is that okay? Good. So look at this gestational sac, no fetal pole, no cardiac activity, and it is the mean sac diameter we got was 27 millimeters. 27 millimeters. This is a classic sign of blighted ovum. So with blighted ovum is a simple diagnosis. You don't see a fetal pole, mean sac diameter is already 25 millimeters and above, forget it. 26, 27, 28, 29, it's gone, except by miracle. So look at this again. So what can we see here? We take the mean sac diameter, longitudinal, AP, transverse. Look at the average. The average is 3.01 centimeters. That's 30 millimeters. Is 30 millimeters greater than 25? Yes, it's greater than 25. What's our diagnosis? Blighted ovum. Simple. Good. So now we have discussed every important thing. So let's just recall some values. Is that okay? Let's recall some values. Remember the intradecidural sac sign, IDSS, not DS, sorry, is usually first seen, can be seen, no, let me say usually first seen, can be seen as early as 4 weeks and 3 days to 4 weeks and 4 days. Threshold level can be about 24 days. The yolk sac, 5 weeks and 3 days. Double decidual sac sign, 5 weeks. Diamond ring sign, 6 weeks and 6 days. So in conclusion, the following are the most important conclusive statements from this presentation. Is that okay? At 7 millimeters CRL, a fetal heart must be seen. Now, take note. It's also documented that for TVS at 5 millimeters CRL, fetal heart must be seen. Is that okay? But what's it called? On TVS, but this time around with what's it called? But then for transabdominal at 7 millimeters CRL is what's it called? A fetal heart must be seen. I prefer we use the what's it called? The 7 millimeters, just to give the benefit of the doubt, and also too, there is a phenomenon called small embryos where sometimes the fetal heart is not seen. We won't call it dead at that moment in time. We would talk about what kind of diagnosis you will give that in later webinars. Is that okay? But at 7 millimeters CRL, a fetal heart must be seen. Must is the word. Must. At 25 millimeters mean sac diameter, a visible fetal pole must be seen. Must see a visible fetal pole. A yolk sac of greater than 6 mm is suspicious of a fetal anomaly. That's a very important statement. And then mean sac diameter minus CRL must always be greater than 5 millimeters. Always. MSD is measured in orthogonal dimensions, the 3 dimensions, longitudinal section, transverse section, and AP, in their inner to inner diameters. These vital facts will help you differentiate 4 different entities: early sciasis, and all of these are diagnoses you can put on your report: early sciasis, pregnancy of uncertain viability, early embryonic fetal demise, and first trimester ongoing gestation on a first trimester scan. If you like to know how to differentiate all of these 4 on the ultrasound scan, do me a favor, join us for the next webinar. So thank you very much for the time. I trust it was worth it, basically, and I trust you are able to gain a lot. Don't worry, the replay is going to be public on the YouTube channel. So you can always go back to the YouTube channel to stream it. That's where you get, what's it called? The replay of this particular presentation. Is that okay? And so that brings us to what the next webinar topic will be, which will be early pregnancy point of care ultrasound, which is that in your point of care, you'll be able to recognize normal, uncertain, and non-viable gestations. Is that okay? Normal, uncertain, and non-viable gestation. So now, let's just briefly test our knowledge, what we have, what's it called, done so far. Let's test our knowledge. Let's test our knowledge. Is that okay? Now I know there's going to be a lag, so I'm going to mention the question and then we'll talk about, then I'll give you some answers. I'll give you some time to talk about the answers. So in this testing of knowledge, you're going to tell me whether this will be a viable, non-viable, uncertain, or it might be too early to, what's it called, to determine viability in these pictures I'm going to show you. So first of all, look at this. Is this viable? Is this non-viable? Is it uncertain, or is it too early to determine? So I'll give you 10 seconds to think about it. You can think about it, you can drop it in the comment section. Okay, so the answer is, I would say it's uncertain. Why am I uncertain? Because I can't see the heartbeat here. They haven't shown me the heartbeat. And that's why I said you must always see the heartbeat before you say it's viable. So though we can see the crown rump length quite all right, crown rump length is from this thing here, 9.1 mm or 0.91 cm. Yeah, is that okay? We are not able to determine viability until we see the pregnancy. Is that okay? Until we see, sorry, that's until we see the pregnancy, until we see the heart rate. Is that okay? So that's this one. This one, so it's uncertain. Until we see the heart rate with the crown rump length, then I can say. So let's look at the next one. Is this viable? Is this non-viable? Is this uncertain? Or is it too early to determine? Okay, so let's see. Give you another 10 seconds to tell me that.
It's viable.
Viable. Oh, fantastic. So someone has already said it's viable on the call. So this is a viable pregnancy. Why is it viable? Because we can see the heart rate, yeah, and then we can see in addition to the CRL. So now for this one, is this viable? Is this non-viable? Is it uncertain, or is it too early to determine? Is that okay? Is it too early to determine? I think this is the double decidual sac sign, if we can see it clearly. Yeah, basically. So is it too early to, so let me give you 10 seconds.
Too early to determine.
Too early to determine. Fantastic. So someone says too early to determine, and so they're very correct. So we got to give this some more time before we determine that. So this one, now this is tricky. Is it viable, non-viable? Take a look at the gestational sac diameter very well. Is it viable? Is it non-viable? Is it uncertain, or is it too early to determine? Ten seconds, 10 seconds, 10 seconds.
It's uncertain.
Okay, fantastic. Someone has said it's uncertain. Okay, so it's uncertain. Okay, I can see it on the comment section. It's uncertain. So why is it uncertain? This gestational sac diameter falls between 16 and 25 mm. It's not 25 mm yet, so therefore we can't say it's a blighted. It's between 16 and 12 mm. There is a particular clinical impression we'll put on it on our reports if we're reporting this kind of a thing. And that one I will tell us in the next webinar at the end of next month, the month of March. Is that okay? So I'd announce it very well on time. So then let's see if there are any other questions. Okay. So, okay, yeah, there's some pop quiz for us. Okay, I have some pop quiz. But before we go into the pop quiz, I'm going to first of all ask you to please subscribe to the channel to get more updates. So just click your subscribe button right now. If you have not subscribed to the channel, just click it and subscribe, and then we'll continue. So just click the subscribe button, subscribe, especially if you have really enjoyed this presentation, then you'll be able to see the live presentation replayed again. So let's do what's it called? Some quizzes. Now, which measurement is most accurate for dating pregnancy in the first trimester? Option A, biparietal diameter. Option B, femur length. Option C, crown rump length. Option D, abdominal circumference. 5 seconds for this. 5.
C.
C, crown rump length. Fantastic. The answer is the crown rump length. Yeah, crown rump length. That's the answer. Good. So let's look at another one. A fetal heart rate of about 60 beats per minute at 7 weeks is what? Is it normal? Is it mildly elevated? Is it concerning for poor prognosis, or is it diagnostic of a twin pregnancy? What's your answer? So 5 seconds. Is that okay?
It's concerning for poor prognosis.
Concerning for poor prognosis. Is that okay? So concerning for poor prognosis. Good. So why is it concerning for poor prognosis? It's because 60 is pretty low. We might not have a very good outcome on the long run. So that's the answer. Then another question. A double decidual sac sign, which we have seen. So I want you to look through the internet and look at these images very, very well. Is that okay? Then you'll be able to, see and appreciate them very well. There's a lot of internet pictures these days. And then if you go on my page, on all our pages, you see many of these things there. So the double decidual sac sign indicates ectopic pregnancy, intrauterine pregnancy, molar pregnancy, fetal demise. Which one of them? 5 seconds.
Intrauterine pregnancy.
Intrauterine pregnancy. Intrauterine pregnancy. Fantastic. People are commenting. I'm seeing your comments on poor prognosis and all of that. See, I'm seeing option C. Yes, you're correct. CRL. I'm seeing all of that. Yeah, very good. So intrauterine pregnancy. Fantastic. So thank you so much. That's the end of all of my questions. Thank you for the time. Thank you for the opportunity to teach you. So again, I tell you, please subscribe to the channel so that you can get more content. Basically, we're going to be having this very frequently. Subscribe, subscribe, subscribe. Subscribe to the channel. You can also share the channel with your people. If you just tell them that there's a place where ultrasound is being shared to to upgrade our skills, to make sure that we're practicing the standards everywhere. Subscribe to the channel. And then we have the QR code here. Is that okay? So this is our QR code. Scan. You can just take a picture of this QR code, screenshot it, scan it, and then it would open you up to the ultrasound community. We have quite a lot of pages. The case dialogue page, where I really like when people talk about cases. Then the community page where announcements happen on Telegram and all of that. So scan in to join and then be part of the community. So thank you very much again. Thank you very much. The end. Please subscribe. Thank you. Thank you. Let's have a beautiful night. Cheers.